So.
No, they're not.
What?
I'm telling you, rattles balls.
You just need to tie things down tight. That's all.
Guys. Yeah.
Fine.
You probably have the radio on now, that's why.
So we're now going to start pulling it. So we're now going to start pulling everything together. Okay. So we're going to look at We're going to start looking at patients and thinking about the difference between what we call low acuity patients, or the little sick patients, the patients who call us and have something wrong with them, but we're probably more of a taxi service rather than actually doing anything. Okay. So for them, we'll still do that full A2E assessment that we do as for everybody, and then depends what the problem. We'll identify a problem. Usually, it will just be one problem, which will or will not require any painkillers, and then we'll find where they need to go. So, for example, if you get called to someone in a care home on a Monday morning who's been going to the toilet more frequently, a little bit confused, but their heart rate is normal, their blood pressure is normal, their temperature's more or less normal, the oxygen levels are normal.
Sunday roast. Sunday roast. UTI.
So thinking they have a urine infection, they might not necessarily need to go to hospital for that. It might be that you call up the GP and say, we're from the ambulance service, this is what we've got, are you happy with our assessment, and you'll treat it based on that, or alternatively, can you please arrange for the rapid response team to come and assess the patient, or you come and see the patient. Okay? So the low acuity patients don't all necessarily have to go to hospital in an ambulance. Another example might be a child who's fallen over and has injured a wrist or an elbow or something, but they're absolutely capable of walking around and screaming and shouting at you because they don't like anybody who's not their parent. So they've got an isolated injury, otherwise they're absolutely fine. We'll give them some painkillers for that, and we can and it might be that their parents can take them to a walk-in centre. They don't need to go and clog up A&E. Obviously, it requires the walk-in centre to be open, so if this sort of thing happens at 7 o'clock in the evening, you might still not have to take them to A&E yourself, but send them to A&E. There are limits to that, because children under the age of 5 have to be taken in by Hatsola. That's the policy. The National Ambulance Service has a cut-off of 2, but they frown quite awkwardly at people who let children under the age of 5 go by themselves, because historically there's been a lot of missed things because of that. So the younger children we tend to be more cautious with them, which means that we take them to hospital rather than letting them go to hospital with a parent. Well, we'll take the parents with us, obviously, but the younger the child, the less likely they are to be able to be sent to hospital, the more likely they are that we'll need to take them to hospital.
With term time, a lot of them be in schools or clubs as well, isn't it? So the parent can't come, normally somebody from school to go, and then the parents
so a responsible adult, and we accept that that parents work while their children are at school. At that point, although the school doesn't have parental responsibility, they are in loco parentis, so a member of the school staff will have to come with. Schools will give a lot of pushback, but that's not your problem. Someone from school has to come with, and then the parents will have to meet them in hospital, and then the person from school will have to come back to school. So
if you're out in the street or something like an RTC or something being knocked over, the police will then fill that role.
Yeah.
So we, in extremis, you're a trusted, what's the word you're looking for?
Trusted professional.
Trusted professional to look after the child. The problem is once you leave the hospital, once you leave them, we're not expected to stay. There needs to be an adult that is just there to look after the child. So that's either a member of staff from school to the parents gets there, or the police. Because again, the hospital staff won't take that role either. So.
Yeah.
Would the police come from the scene, or the police might meet you at the hospital?
No, if you're taking a child from the scene, the police will come from the scene with you.
They should be.
They should
They
be.
should already be at the scene.
If they give you a little bit of pushback, always gently remind them that it is part of their role. And actually, the police tend to be very supportive, so it's not.
Yeah, it's not an issue. They don't necessarily have to be in the back of the vehicle with you. Often they are, but yeah, they might follow.
Yeah. Okay. But think about where we can send people. So there's the rapid response teams that we can sometimes access. There's a GP we can access. We can sometimes the weller patients we can sometimes refer to the walk-in centres.
What are the rapid response teams? Is that like on-call GPs and things? What's the rapid response team?
So there's a sort of crossover between GP and hospital. So it's led by usually a geriatric consultant. It's more for older people. And it's a team of nurses that will come out, they'll see the patient, they'll assess the patient, they'll dip their urine, do blood tests.
So is that more of a care home with liaise with the GP and the rapid
No.
response?
So this is for people who are not in a care home. These are for people who live in their own home and are independent.
It's a mobile medical.
So who liaise with the dispatchers liaise with the rapid
No.
response?
So it would be. Usually would be you'd speak to the GP and the GP would arrange it.
Okay.
If you decide to progress up the slippery pole and become a paramedic, then it is something that starts opening up to you. But it's more you'll have a discussion with the GP and it will be something the GP can arrange. Okay. Basically, you're handing over the care without taking the patient to the hospital. If you can't do that, unfortunately, the default is you have to take them to hospital. So if the GP, if it's a Friday evening at 7 o'clock, which means that the walk-in centre is shut, the rapid response team are closed, the GP is closed, you end up taking very minor things to A&E, and it's a shame, but that's what happens because we can't provide that ongoing care or the further investigations that are needed, even if it is something quite straightforward. Okay. Now, if the patient is somewhere safe and it's the middle of the night, then you still have the option, and you think that it's a GP issue, then you can call 111 and speak to a GP in 111, and that is still an option. So that's what I'm saying. You don't think that everybody has to go straight to hospital. Okay. But sometimes
we would wait there for the GP to then call back.
So
111, they triage it, don't they? And then
so 111 triage it, and if you call up and say you're a healthcare professional, then you automatically get a call back within half an hour. So you're making a referral to a healthcare professional to a healthcare professional.
Do you guys have backdoor numbers?
And there are backdoor numbers, yes. So you call the backdoor number. Well, I can't. This is going to be on YouTube, so I'm not going to say it because then 111 will send them
to change their number, right?
Yes. Yeah. There are backdoor numbers, and they put it in as a healthcare professional to healthcare professional call, and they call back within half an hour.
We'd be liaising with our senior.
Yes, and I mean I've used it very successfully many times, and it's saved a lot of patients a lot of grief, especially the patients who, for whatever reason, shouldn't be going to hospital. Getting that set up for them has been really effective, and I've had a few patients, especially the more elderly, frail patients who have a decision that they are not going to hospital, whatever it is, that is a really effective thing for them. Okay. So think about the referral pathways and the handover, because we're still handing over that responsibility. It's just we're not doing the normal handover where you go to A&E, speak to a nurse and say, please sign on the dotted line here that the patient is now in hospital. It's a slightly different form of handover. Yeah. So those are the low acuity patients, okay? And then we've done or we could have a patient who we assess as being high acuity, yes? So the patients who are very unwell, so they have a high temperature, tachycardic, low blood pressure, low oxygen levels, whatever. We assess they have a severe injury that they need immediate treatment. So again, we're going to have that full A3 assessment, where we'll also be looking about the catastrophic hemorrhage and all those things with more seriously injured. Thinking about how we're going to, if they're in pain, what sort of pharmacological options are available to us. So thinking about paracetamol, ibuprofen, opioids, and thinking about non-pharmacological ways of treating pain. So today we were doing splinting. That is a form of pain management. Okay, distraction. So not pulling broken bones apart, which is still a form of distraction. But distracting someone can sometimes be a form of pain management as well. So think about the other options available to us to help with managing pain. And that comes with thinking about the medications that are within your scope of practice. So not everything you can do. So you can't give opioids, yes? Depending on your level of training within Atsola, if you've passed the drug module, then you can give paracetamol and ibuprofen. If you haven't passed that module at FREC level 3 and level 4, it's a national qualification. You're not able to give the medication, but it's still important that you recognise that they need it, so you can get someone who can do that. Okay? Because just because you can't do something doesn't mean you don't need to facilitate that from happening. Okay? Thinking about what other services you need to help you. Okay, so if you're stuck at the top of a house with someone who needs to be taken down 2 flights of stairs, are you capable of doing that, or do you need other emergency services to come and help? Fire brigade are really good at doing extracting people. Think about that. Think about if you've gone somewhere and you can't get in. Do you need the police to be there with you? Yes, you were about to ask.
Drug module obviously covers more than paracetamol
Yes.
and ibuprofen. Why is the welfare person at a school able to give with paracetamol and ibuprofen? But how does that differ between?
How does it differ? It differs because of the national standard of training that we're teaching you to. So we're teaching you to FREC 3 level at the moment, and that doesn't include administration of medications. The welfare person in school has a signed piece of paper from a parent saying that should Shlomi fall over and graze his knee, you can give him paracetamol and you will give it according to the instructions on the box. It's not to belittle your knowledge and say, no, you're not capable of giving someone paracetamol. It's just this is your training standard doesn't include administration of medications. That's fine. That's just where the national standard has been set. Okay? It's just like a healthcare system in a hospital will recognise that someone who is complaining that they've got a headache will benefit from paracetamol, but they can't give it.
Is it more the case of you've been called out in an ambulance, so there's probably something more going on, even if the president gives permission for paracetamol, the qualification?
Potentially, yes. That doesn't mean to say that if the parent or the person says, "Can I take a paracetamol?" you can't say to them no, because actually it might be appropriate, and they are allowed to take painkillers. It might be you say to them, "Have you thought about taking some painkillers?" And they give you a very strange look because they're a young man, and you say to them, "Well, it might be a good idea to take something for your stubbed toe." Yes, the number of young men that I have seen in A&E who come in and say that they have not taken any painkillers for their headache, and I say, "Why?" And they said, "Well, I want you to see how much pain I'm in." I say, "Okay, fine. Now do you want to have some paracetamol?" And they say, "Okay." So I say, "Go and take some paracetamol," and that sorts the problem out. We spoke already. No, we didn't speak. I spoke. It was a different group. Pain is a subjective experience. So my pain is not your pain, and your pain today is not your pain yesterday, and is not your pain tomorrow. So it's a feeling that you get, and it's how you interpret that sort of thing. Now, pain is a warning that something is potentially going wrong with the body, but not always, and that's why it differs. And we will all hear patients say, "I normally have a high pain threshold." Invariably, it's a 40-something-year-old lady who's already had a couple of vaginal births and is very proud that she had without any epidural or anything or gas in there. But except that now the pain is different, and that's okay. So you normally have an excellent pain threshold, but now you need some painkillers. It's not a deficiency. It's not a sign of weakness. You are allowed to have painkillers.
Is it like pain level, the threshold? Is it like someone have a like for example, I remember that said that I have my kidneys pain.
Yeah.
It was more than the bill. Does it mean that usually is more than bill?
So on the whole, we know that contractions are quite painful. We know that kidney stones are quite painful. We know that a broken bone is quite painful. That doesn't necessarily mean that each time that person experiences any of those conditions, it will be exactly the same.
So there's not any like
It's-
lateral.
There's no. It's how someone feels. It's what someone feels it. Okay.
And is there any way to monitor pain?
Yes. You ask the patient, how bad is it now, and you ask them to rate it. 10 is the worst pain you can imagine. 0 is no pain at all. How much pain are you in right now?
So it utterly depends on what the patient tells me. So for
Yeah.
example, someone with a myocard, listen, it's 10 out of 10, and I'm asking
That's
them-
fine.
Yeah.
It's not a problem. That paper cut could be 10 out of 10 for them at this point in time. That doesn't mean that tomorrow when they get a paper cut, it will still be 10 out of 10. But right now for them it's 10 out of 10, so we'll offer them some painkillers.
So in the case that we need to, like we have multiple casualties,
Yeah.
I need to decide what treatment.
When it's multiple casualties, we're not interested in their pain level. We want to know, are they about to die or are they not about to die? If they're in pain and they're screaming at you, you know they've got a patent airway and they're breathing, and you're not worried about them. Yes? That's fine. But that's not to say that we're going to ignore their pain later on when we have the ability to actually treat them. When we've got multiple casualties and we're trying to work out whose life can we save and whose life we can't save,
Obviously.
then unfortunately pain is an indicator that your life can be saved, but is less serious than the person who is not able to breathe and therefore can't tell us about their pain. Okay?
And it's relative to your experience of pain previously as well.
Yeah.
So if you do people do lots of contact sports, horse riding, hurt themselves a lot, their experience of pain is different to people that don't do that. They're normally they are able to their pain. If you ask them how bad their stubbed toe is, well, it wasn't as bad as 3 weeks ago where they broke their leg. So then it's a much lower pain level to them.
And I'm happy to share an example. I have stepped on Lego bricks and they are absolutely exquisitely
10
painful.
out of 10. Yeah.
I have a pebble driveway and I walk very, very, very gingerly across the driveway because it's as painful as stepping on a piece of Lego. My neighbours walk around barefoot on the driveway and don't seem to feel it at all. And I honestly can't work out why, because I love the gravel driveway, but it is really painful to walk on barefoot. But other people clearly can walk barefoot on gravel driveways. Yeah. So it's an individual perception. It's not, and it will depend on where they are in their frame of mind at that point in time as to whether they can manage it or not.
And what you think will be a more painful injury to that person might be less. So for example, I've dislocated my patella doing, so someone fell across it doing martial arts. That was incredibly painful. Getting knocked off my bike and breaking 2 bones was less painful than my patella. But the injury severity is way different.
Yeah. So what the point is, don't dismiss when someone says to you they're in pain. It's not, no, you don't look like you're in pain. If they say they're in pain, accept it. Offer them painkillers within your scope of practice, which at FREC 3 level is, have you thought about taking some paracetamol or ibuprofen, and let me call someone else who can give you more painkillers if needed. Yeah. And thinking about what can you do to distract them. So if it's a 3-year-old screaming their head off, Thomas the Tank Engine or Peppa Pig or whatever the latest thing is, getting them to watch that might be enough to calm them down enough that you can provide them with the extra care that they need. Okay. So it's a very individual experience, and you need to work your way around it, but accept what they're saying and honour and respect it, basically. If they say they're 10 out of 10 pain, don't argue with it. You don't look like it. Yes, okay. Have you taken painkillers? Yes or no? Yes. Well, what have you taken? Let me see what else I can do. No. Why don't you take some paracetamol? And let's see how things are in 10, 15 minutes. Paracetamol takes longer than that to kick in, but at least you're doing something and you're starting to address it, and that helps them, and you know where you are. And if 15 minutes later it's still exactly the same, great. That's what I was expecting, because paracetamol takes a bit longer than that to kick in. Let's keep going and seeing how we go over the next 10-15 minutes, and by that point, hopefully we've already started making progress towards hospital and getting a resolution for the problem, and then the painkillers do actually start kicking in and they start feeling better as well. Okay? And just remember that the psychology of you being there, looking after them, will already take away some of the stress and the pain that they're experiencing. And it's very true that when you turn up in the high vis, that in itself is part of the treatment. Whether it's needed or not doesn't matter, but that is part of the treatment. So don't worry about it so much. Accept what it is. They say to you it's 10 out of 10. Okay, let's do some simple measures first. Think about what else we can do, and move on with it. Okay. Don't say to them just sitting there still, not crying, so it can't be 10 out of 10. Or when they say to you, I've normally got a high pain threshold and this is really, really bad, don't say to them, you're talking rubbish, you don't normally have a high pain threshold. Fine. That's your perception of pain at that point, and this is your perception of pain right now, and it's not a reflection. Okay? Thinking about also how we're going to hand over, so we've already spoken about ATMIS and SBARD. So you have that structure, so you know what you want the person you're handing over to, so you know what you're expecting them to do. In hospital, this is a story. I'm expecting you to take over the care from me. Yes, I want you to look after the patient. But sometimes it's also helpful what you want them to do for the patient. So say you've had a patient on the back of the ambulance for 2 hours because it's been really ram-packed, and the patient is absolutely desperate to go to the toilet. Part of that will be the patient needs to go to the toilet. I'm expecting you to take the female patient to the toilet to put them so they can go to the toilet, because I am not a female practitioner and I think it's a little bit inappropriate. It might be that actually we're male practitioners and there's a few of us there and there's no one else, so therefore we will do something relatively appropriate to help the patient. But that's part of the situation. So SBAR, which is what I use quite commonly, situation is whatever. The background to the situation is the story that brought us there. This is what I found on my assessment, and this is my recommendation to you. Please take over care from me. And the decision is that you're going to be the carer. The patient needs X, Y, and Z doing right now, and the rest of it you can sort out later on. Okay? Does that all make sense? We're then going to think about environmental factors while we're assessing the patients. So thinking about where we are. So we've all been practicing putting patients on the spine boards and think, where are we? Are we at the top of a tall building? And we've got a long way to go down, and it's one of those really old buildings with a lift that says 2 people no more than 160 kilograms, and you think, well, all my equipment and the patient and me is far more than 200 than that, and how are we going to get down? Are we on the ground floor? Are we inside and we have to get out through narrow doorways? Are we outside and it's really, really hot, and the patient is at risk from having a heat injury? Are we outside and it's really, really cold and we're at risk of having a cold injury? Yeah. Are we somewhere and there's wasps all over the place? Are we next to a stream and there's risk? So thinking about the things that might be there that might cause problems with looking after the patient and pose a risk to us and the patient going forwards. Okay, and recognizing that we do not work in a controlled environment. It's not a resus area that you have your stacks of machines and oxygens placed conveniently by the patient's head, an anaesthetist there, and lots of other people there to help you. This is outside, and there are risks and limitations because of that. Okay, think about the extra equipment that we have. Think about the extra training that we need. Yes, we haven't yet looked at going up and down stairs yet. So thinking about, well, how do I get up and down stairs? What training do I need to be able to do that safely, so I can get the patient safely downstairs without injuring myself and without dropping the patient and causing them any harm? Okay. and also recognising what other services are able to offer to bring to help that. So thinking about the fire brigade for extraction from places, thinking about the fire brigade to help us with, because the fire brigade are very good at stabilising cars in accidents, thinking about the police to control an environment, thinking about the police, they might bring legal powers to help us. So if we've got a patient who's got mental health issues and actually the patient isn't able to make a decision because of that, thinking about whether we need the police to help us make that decision on behalf of the patient, that they need to have that extra care against their wishes, okay? Because no one here is allowed to impose a treatment on someone else just because I think you need it, yes? I noticed some of you have left here their vape, not now, before, yes? Now I'm quite against that because I think that you shouldn't be inhaling nicotine-containing products because they're addictive and they're bad for you. That doesn't mean I can impose upon you that you're not allowed to do that. I can tell you you're not allowed into my house if you do that. But I can't say to you, no, you can't come to the course because you vape. Because you're entitled, within the realms of what's legal, you're entitled to do whatever you want. Okay? So we need to think about that and think about what additional services we might need to help with that. Yes, did you have a question?
Can I tell a client, like for example, if you're smoking here, please stop smoking?
Yeah, so when we come to look after someone, if someone calls up at Solar and they smoke, you can say to them, I've got an oxygen cylinder here, you have to stop smoking, it's a fire hazard. You are entitled to say, it's really bothering me that you're smoking, and you have a choice, you can have someone else look after you, but I don't know who can come, or you stop smoking so I can look after you. And that's a reasonable thing to say. Just because I decide I want to smoke doesn't mean I can impose that onto you who doesn't smoke. Yes? Yeah? If they have pets in the house, just because they have pets and they like the pets doesn't mean that they can impose upon you to come into the house, to be in the same room as the pets, which are going to be very excited by the fact that it's a stranger in there doing all sorts of weird and wonderful things to someone who they care about, and you might feel very much at risk. Because you're absolutely entitled to say, well actually, before I come in, make sure the dogs are locked up are in a different room with the door closed, for example. Yeah? And I very commonly will say to, when I go on home visits, I will say to people, sorry, but you need to put the animals in a different room and close the door before I come in, because I can't work with that distraction. It puts me at risk and it puts you at risk. And I appreciate the dog is lovely and everything and is really well behaved and whatever. When I'm here doing something that's unusual, I can't take that risk, and that's fine. And if they don't respect it, well, that's their choice, but they can't force you to go into that environment. And I certainly know plenty of people who, as soon as they turn up, if they hear an animal, they say, is the animal in another room that's closed off? Because actually, even really well-behaved animals, when we turn up, it's strange, it's unusual, it's stressful, and they will act out. Do you find that?
Yeah, so the I don't know what, in terms of your control, but if it comes through 999, the instructions are to put dogs away, particularly. Whether most people follow that, if they don't, then most of the time.
I mean, we don't give that instruction because people don't, the dispatchers don't really ask that sort of question. But if you get there and there's a dog, it's sensible to say to them, I appreciate the dog's really well behaved and everything and lovely and everything, and it's a little pips that you stare at and it falls over.
The little ones are worse, aren't they?
But so so that we can do things safely, can it be in another room?
And certainly if you're just going in and sitting down and having a chat, that might be less risky because the dog doesn't see that as a threat. If you're going in and starting to do things in and around their
CPR,
own,
for example,
or even just
even just taking their blood pressure,
or just touching them and taking them, they might see that as a threat and they might come towards you. So generally speaking, if nothing else, they're just going to bark. So then even that is a distraction and a problem. So you just get them removed.
Yeah. and they tend to bark and do everything in another room. It's quite distracting to have something going on in the background. But at least you don't have to worry about the dog barking and doing something unexpected while you're there. It's fine for them to bark somewhere else, but not in the same room as you. Or cats, they're absolutely vicious with their nails.
Cats. Yeah, you can't get all the cats in your bags or all over the place.
Yeah. Okay. On that point, if you are sitting down, make sure that you know what you're sitting on.
I don't sit down.
So yeah, I tend to not sit down in patients' home. At the very most, I'll kneel on the floor, but it's risky, shall we say? On the other hand, you do go to some places, and you know it's absolutely spotless. I mean, I've been on home visits where I open the door, and before I go in, I take my shoes off because they've got lovely cream carpets, which are spotless. And you know, if they've got cream carpets and they're spotless, it's unlikely that this is going to be a messy house. But yeah, someone will probably tell you you shouldn't be taking shoes off while you're at work. But I think if you're going into a spotless house and you're sitting on the couch with someone, having a chat with someone,
you do dynamic risk assessment.
It's your dynamic risk assessment, absolutely. Okay. So we spoke about different things that can affect safety. So thinking about being on high places, if you reach down, gravity's pulling you in that direction. Think about that. How are you going to do that? Snow and ice. It does occasionally get cold in England. I know now's the wrong season, but I distinctly remember being in some very cold places, and you driving at 10 miles an hour seems really, really fast. Or standing outside and doing CPR in the snow is really, really cold.
Do we have snow chains and things for ambulances and stuff?
Yes, the ambulances do have snow chains, and there's lots of salt by the ambulance station, but that doesn't help you so much when you're driving along the A1 towards Barnet Hospital, and there's 2 inches of snow which has been slushed up by all the other idiots in front of you who have no idea about the fact that if it's snowing, don't just stomp your foot on the accelerator and spray it everywhere and crash on the way while you're doing that.
And it doesn't sort out people's driveways and doorsteps and stuff.
Yeah.
I went to a call years ago now, in the snow, on the ice rather. Male patient slipped on his doorstep, had probably, I think, fractured his shoulder in the end. He'd gone back in and upstairs anyway. So he was fine to walk out. We stood and walked him down. It was cold outside, so we stopped in the foyer. And my crewmate went out to unlock the ambulance, open everything, and get it ready before we came out. She slipped on the same bit of ice that he slipped on and did the opposite side. So I had both of them now in the back of the ambulance like that, and we drove them both to the hospital. So yeah. It's a risk.
It's a risk, and it's a real risk. Flooding is a risk. It does occasionally happen, even in Edgware. Depends where you live. I've chosen a house which is on Broadhurst, so it's nice and high up. But if you decide you're going to live on Brook Avenue, it might get flooded when the brook overflows. So those are things to consider. I'm not aware of any caves around Edgware, but potentially if you go that's a risk. Fires are always a risk. Don't put yourself into them. Thinking about things falling from above does occasionally happen, especially if they build that massive eyesore by the station in the next few years.
They will.
What?
And they will.
I think they will. Yes, I think realistically they will.
The bus station underneath.
Yeah, with the batteries.
Yeah, perfect.
So you have fire underneath and everybody's jumping from upstairs, and they will call out solar because that solar's local, because they already do.
I'm not in that day though.
What?
I'm not in that day.
Yeah, that's fine. Okay.
You're well with me.
Yeah.
Does that all make sense? Okay, so it comes back to that dynamic risk assessment, but remember it's dynamic and it goes both ways. It's dynamic for you and it's dynamic for the patient. Okay. Recognising the effects of environment. So if someone's out in the cold, even if they're dressed properly, if they're not active, they will eventually become cold. And going back to the cardiac arrest that I went to in the snow, halfway through the cardiac arrest we made a decision that we needed to get somewhere warmer because all the responders were getting cold. And you've all practiced doing chest compressions, you know how energetic that is. But even with that we were getting cold. So think about that. Think about the hot environment. So today we had something with the fire brigade, and I literally got into the car and I was drenched in sweat. So it can affect, if you're sweating so much and all the sweat's dripping into your eye, it can affect your vision. Sweaty hands, you feel uncomfortable, it's difficult to do things. When it's hot you can't concentrate as well. So think about that, think about what sort of things it can affect. And then thinking about what sort of effects. So we know that so if people are cold, they'll start shivering to maintain their body temperature. That's okay in normal temperature when the environment's a little bit cold. But once they start getting below 35 degrees, then the effects the shivering starts becoming less effective. So they'll get fatigued. The brain won't work so well, so they'll start having slurred speech. They'll get confused, forgetful. As they get cold, the shivering stops because the body isn't working as effectively. The body's trying to conserve heat, so you start losing peripheral pulses, and then if someone's cold enough, they might appear dead, and that's why and there's been a couple of cases over the last few years of people who've been so cold that actually they've not had a pulse, they've appeared dead, but with resuscitation over prolonged periods of time they've made it, and they've been resuscitated. And there was a doctor in Norway who was clinically dead for a couple of hours and made a full recovery so that she could go back to practicing as normal. So just recognise that they might look dead even if they're not dead yet, if they're very cold.
Clinically dead, it's...
So clinically dead, that she had no pulse, she wasn't breathing, her ECG I think showed asystole, yes, so her heart was not beating and there was no electrical activity, so she was dead, but they resuscitated her, warmed her up, and she made a full recovery.
They do that with that, ECMO machine.
Yeah, so they can do the things, so ECMO machines can help with that as well, things like that. Then excessive heat, so today was a nice example where you walked outside and you literally drenched, and I know that when that happens to me, I literally sweat buckets, and I got into the car and very annoyingly the light has been left on. And I tried starting the car and it didn't start, and I realised I needed to jump start the car, and it took me quite a while to work out how to do that. So I went to get the jump starting battery from the neighbours and that didn't work, and I thought, well, clearly that's not powerful enough, so I went and got another car and I parked in front of it and the wires weren't long enough. Like, this is a great thing. It took me so long to work out how to actually plug the cars together to get them jump started, and it's something that, like, I sit to think about it now when I'm feeling comfortable in air conditioning. It's like, what took so long? But it was so hot I couldn't think. No. Okay. So there's that. If people start getting heat exhaustion, so they get muscle cramps, they get nauseated, they get abdominal cramps, they become unsteady, they become very sweaty. They're trying to lose that heat by doing all this, and then when they get even hotter, and they start getting heat strokes, so they start losing these compensatory mechanisms. So they'll stop sweating, they'll have reduced consciousness, they'll have less ability to control their body functions, and until they essentially cook and that can kill them. And that can be not just if it's an environmental injury, it can be if someone has an infection as well. If they've got prolonged high temperature, this can happen to them. And especially at the extremes of age, they sometimes might have convulsions with it, so febrile convulsions, quite common actually between about the age of 6 months and 6 years, but it can also happen to physiologically older people, so people who have very poor health. Even when they're older, they can also develop febrile convulsions, and it can look like a seizure. They get labelled as being epileptic when actually they've had a convulsion because of heat. Okay. So it's important to recognise these things. Okay. Then thinking about us in this, so when we're providing this care to patients in these environments, so we're still going to use the A2E assessment so that we can identify what's going on. If it's heat exhaustion and stroke, the most important thing is to remove the cause of heat from the patient. Now, if it's because they've got high temperature, cool them down. If it's because they're outside on a day when it's 40 degrees outside, remove them from outside, put them in the back of the ambulance with the air conditioning on. Undress the overly dressed patients, so we will all get to see children who are 9-10 months old-ish, plus or minus, who've got a temperature of 40 and they're shivering, so their parents wrap them up in a vest, a baby grow, a sleeping blanket, a duffel coat, a onesie, and they crank the heating up because they must be cold because they're shivering. Well, yes, they're shivering because they're approaching convulsion territory, not because they're cold. And just undressing them makes them feel a lot better. Okay, spraying them with cool water to help with that evaporation effect to help cool them down is something that can be done. Making sure that they're rehydrated, so making sure that for the sweating that they've done up until they've stopped, they've lost all that water. Make sure that they're getting all that water. Now, you don't have to give them isotonic water to drink because it tastes quite horrible. Just normal water will do. And if it's cold water, it might feel quite comfortable and will also help bring down the temperature because they will lose heat through that cold water warming it up. Okay. If they're cold, so again, remove the patient from the cause that's making them cold. I've got a brother who is a industrial freezer engineer, and he's very conscious of the fact that he goes to work in Israel and it can be 45 degrees outside, and when he's at work he's working minus 18 degrees as a maximum temperature, not a minimum temperature, maximum of minus 18 degrees. So he will go wearing full skiing clothes, and you can think the problem there is he's in work and that's okay and it's appropriate, and he walks outside and he's at risk of heat exhaustion. Or if he's dressed appropriately for outside and he goes into work, then that's not so far removed, because we certainly have people here who will work in freezers. So people in shops where they have frozen stuff, they might spend a prolonged time in the freezer working in the freezer, and they've gone to work on a day like today wearing shorts, t-shirt and flip-flops, and they spent hours inside the freezer and they now have a cold injury from that. So remove them from that. Shelter the patient if it's outdoors, or if they're in a place where so make sure that they're in a protected space. Get wet clothing off them, because again there'll still be an element of evaporation there, and that will cool them down even further. So, you okay?
Yeah. I need money to fill up the patient.
I'll talk to you about that later.
Okay.
Think about putting insulating material underneath them if they're sitting on a marble floor. Sitting on a marble floor is brilliant when it's hot outside, isn't it? Because it feels nice and cold. But it's not so brilliant if you're cold already, because it will continue making you feel cold. If they're awake enough, you can give them warm drinks. So the same thing as if you give a cold drink to someone who's too hot, you give a warm drink to someone who's too cold, and that will help them warm up. And we've all sat there holding a lovely hot cup of tea on a cold day, warming our fingers, haven't we? So it works. And again, monitor their consciousness. Yes?
Question in the case of hypothermia,
Yes.
it's all around in the street for that.
Yeah.
All over, very cold. should I remove his clothes and put a thermal blanket? Or
So if his clothes are wet, yes, because wet clothes make you cold. If his clothes are dry, then you can wrap that with a thermal blanket, absolutely. But think about what's causing him to be cold. Is it because he's wearing the right clothes for their environment and they're working and preventing him from getting colder, or are they the wrong clothes for their environment for whatever reason, and therefore you have to remove them? Okay? But obviously, if it's freezing and he's sitting in a sodden coat, don't remove that sodden coat off him while he's still outside. Get him out of the cold outside, i.e. get him into the ambulance and at the same time remove the coat up there. Okay? So you don't make him colder.
And it's important to remember with patients, once they are hypothermic, so they go below 35, they're not generating their own heat as well. Otherwise they would have done already, they would keep themselves warmer. So they've passed that mechanism. So if you put a full blanket over them, they don't get any warmer just by the foil blanket, because the foil blanket doesn't heat them, it keeps the existing heat in. So that doesn't warm them, they need to be warmed. So when you get them into the ambulance and they are wet clothes or whatever, sometimes you can wrap them in a blanket, but then the heating needs to come on because you're going to heat them externally. Keep the foil blanket off because that keeps the heat out. Right? Yeah. So you need to warm them up and get that heat trapped in. If you have I don't know if you carry the thermal blankets, the heating blankets.
No.
So I've got heating blankets. We put the heating blanket on, and then the foil over the top of that, so it traps that heat in, not just the patient's own heat. Because by the time they're cold, they haven't got enough heat to trap in. Yeah.
Okay. Thinking about drowning, so it can be fatal and non-fatal. So drowning is a process, and at the initial steps, people will get a laryngospasm, so the airways will close off because of the irritation from the water. And then after a period of time, they can no longer hold their breath, and that relaxes, and they take a deep breath. And if they're still in water, their lungs get full of water. Okay. Now, there's two ways to drown. Someone can get submerged, i.e. the airway goes below the level of the liquid. Quite a risk for babies who are left alone in the bath, where they fall over forwards and they're not able to pick themselves up. So although the baby is outside the water, their mouth and nose is in the water and they can't breathe. Yeah, so that's submersion. Or the other way is immersion, where water gets splashed onto the face. Okay? And that can still not necessarily be the entire body's in water. Okay? But it's all about where the water is in relation to the face. Both of those can be fatal or non-fatal. Non-fatal, obviously, we still need to worry about it, but the fatal ones will be in cardiac arrest, and we need to think about that. And it might be quite difficult to resuscitate them because they've got lungs full of water that we can't do very much about at that point. Yeah? Does that make sense? Okay. You need to think about the safety aspects about retrieving someone from water. Are you able to get into the water and get the patient out safely? Is it safe for you to go into the water? No? There were those boys last winter who went ice skating and went through the ice, and the fire brigade tried to get them out, and they couldn't get them out because the ice just wasn't stable enough. Yeah. And there were those people last week who went swimming and got swept away. So think about, is it safe for you to go in and get them? Think about what other injuries they might have sustained in that exposure. If they've jumped into shallow water, have they injured themselves over and above the fact that they've drowned? Okay. It was quite interesting to read the article on the BBC yesterday about going swimming and thinking about if someone is drowning or someone is in difficulties, the fact that they're so panicked whether they pose a risk to you. Even if you're a competent, strong swimmer, are you able to compensate for the difficulties that they're going to present trying to get them out because of the panic and the stress? Okay, and they were saying about actually it might be safer and better for you not to go in and get them, but to call someone else. And there's been a couple of fatalities over the last few months of people who've gone in to save someone. That person has been saved, but the person who went in drowned because the person who they were saving overwhelmed them. So they themselves would have been okay, but because they were trying to help someone else, they got overwhelmed and they drowned. So think about what could happen. Don't just say, oh, they're in the water, I'm jumping in to help them. Think about but it is quite risky. Okay? And then remember, if the water's cold and they're hypothermic, there's a risk that you'll become hypothermic jumping into it. So again, you need to think about that and it comes back into that safety element. Are we safe to provide the care that the patient needs, or are we going to end up having two patients? There's a patient that needs our care, and we go in to help them and become a patient ourselves. Okay? Going back to Richard's example of his colleague on the ice, went out, slipped and broke a collarbone. Now there's two patients for Richard to look after, not just the patient who slipped initially, but also his colleague. And it is really difficult to look after two people, even if all they have is just a broken collarbone. And so think about that. Don't make yourself a patient because you're trying to help someone.
The other thing just to be mindful of in mechanism in water is if they've come off a bridge over a certain height, water becomes a hard object to hit. So most of the London bridges in central London are too high to jump from, so they'll end up with blunt force injuries like broken limbs, pelvic injuries, on top of potentially a drowning, either fatal or near fatal.
And the water over there in Thames water as well.
It's not the cleanest of water either.
Yeah.
So there's all the bacteria in it as well.
It's deep enough to go into, but water doesn't compress, so they'll hit it at a speed that's enough then for them to get blunt force injuries. Then it's got a current and all that kind of stuff as well. I mean,
I wouldn't jump into the Thames if someone else jumped
absolutely
in.
not. It's what the lifeboat's for. And the other thing, working around water. So even like with here, where we were just, we were quite close to the table, people are standing up and that. If you're close to the edge of the water and treating someone that's pretty ill, you're probably going to fall in the water because you're focusing on them and not necessarily the surroundings. So when you do treat them, try and move them or get them moved a decent, safe distance away from the edge of the water so that there's no chance you're going to accidentally go in. Because it's really easy, and we see it in, it's not water, but on the underground where people are treating on platforms and then just fall in because you don't notice the step, you're focusing on what you're doing, you just misstep and you're gone. Yeah.
Okay. So it's a dangerous environment, respect it. Okay. So we've spoken about the effects of cold and heat, so we've spoken about the theory, the cold, hypothermia, the shivering, and then the stopping shivering, the lethargy, the confusion, the weaker pulse. It was one of my radios, I think. Okay. We've spoken about cold injuries, about the direct effect that can have on tissues. So you can have direct cold injury, and then you have more systemic things. We've spoken about heat injuries, so the confusion, sweating, so you can get dehydrated, and then you can lose that mechanism, so the body can overheat. We've spoken about the signs that we might have, so someone being very cold, so that initially is shivering, they'll say they're cold, and then they'll feel cold when you assess them, temperature will go down, so these are all signs, symptoms. They might them reporting feeling cold, they might complain of not feeling well, they'll potentially be more confused, so these sort of things that they tell us about it. We've also spoken about how people can lose heat, so losing it to their environment by sweating, by being in an environment that's cooler, thinking about that. And we've spoken about how to manage these, so cold people will warm up, but we'll make sure we're doing it in a safe environment. Hot people will cool down. We spoke about various things that we have available to us in the pre-hospital environment that can help us with doing that as well. Okay, does that all make sense? Okay, and then just to summarise, we've spoken about the difference between immersion and submersion incidents. So submersion is
underneath water.
Under the water.
their airways under the water, and immersion is water's on their airway. Absolutely. Difference between fatal and non-fatal drowning. Yep. Spoke about different causes of drowning. Yes. And the things that we can do, so we can open the airway, suction out what we can see, give them supplemental oxygen, assisted ventilation, bearing in mind that might be more difficult if they've got lungs full of water already. And think about when we hand over to someone, think about how we're going to hand over, what sort of problems they might have. Okay. Anybody who's been involved in drowning needs to go to hospital. If it's fatal, and therefore they might not be going to hospital, they will be going to the coroner. So the coroner is the lawyer who makes sure that the death is not criminal. They don't care if the death is non-accidental, they just care if it's criminal or not. But because of the potential serious injuries that they can have, even if it was just a mild, non-fatal drowning, so little baby, face down in the bath, found by mum within a couple of seconds, taken out but still coughing and spluttering, still needs to go to A&E because they might have inhaled enough water to cause them damage, even in that short exposure. Okay, so it's not, oh, it's okay, they're fine now. They're fine now, but they still need to be assessed properly. Okay. We spoke about the safe approach, so thinking about the scene, making sure that we're a good distance away from the source of drowning, making sure that we've got the right people to get the person out of the drowning. So if it's a child in a bath, yes, absolutely, it's not a problem for you to take them out. But if it's open sea, don't jump in with them. If it's a shallow swimming pool, don't jump in, but it's absolutely fine to wade in as long as you know you can reach the bottom. Thinking about the difficulties of someone who's in that sort of state and the risks to you with that. Okay, and lots of drowning incidents don't necessarily occur in deep water. They can occur in shallow water, but even that has overwhelmed the person then. Okay.
Just on that with flooding, so where roads are flooded, so it's not a normal bit of water, it's something that shouldn't have water in it now has. Generally the advice is you shouldn't be walking in anything that you can't see to the floor in. That's irrespective of the depth, because you won't know the depth. The reason for that is manhole covers and flooding will come up. So when you're walking across the road, the drain cover will be up, you won't know, and you'll go into the drain cover. And the water will be flowing so fast and you won't come back out because it's already flowing. So that's why the picture was up early, you see the team in the gear and in a boat. So they were walking in water up to their knee, but they had patients in a boat. That's because it's risky walking in water where there shouldn't be water. So normally heart teams and people that are trained will walk with a stick and they'll hit the floor in front of them to check there isn't a manhole cover or something up, so they don't go down it. Because if you go down that and no one is getting you back, you've gone and you're down the drain system long before anyone can get you. So bear it in mind, if you can't see the ground in flooding, be very careful about walking through the water even if it's quite shallow. Yeah.
Because it might be shallow here, but not in the next step. Okay, and we've spoken about referral pathways before, thinking about the lower acuity patients that might not need to be in hospital but still need some medical attention, and the options that are available, so 111 GPs, walk-in centres, rapid response teams. There are other things that are available. Not the less unwell patients don't necessarily have to be in hospital for that. Okay, or sometimes you're going to have patients who are more unwell but have a care pathway, and actually following that pathway or facilitating that pathway is really important, because they'll have a better outcome with that treatment rather than being dumped in hospital with no one knows, then they'll get worse. Okay. Any questions about any of that? That neatly brings us to 11:15. According to the slides, the next thing is a multiple choice question exam. So I think we're going to stop there. And what we'll do is we'll do the multiple choice assessment at the next session. We've done some of the practical assessments already. Okay, we'll just check what other practical assessments are, and we'll make sure that we get all of those rounded off so that and hopefully we can finish the course in another day, or as in another session, at the very most 2 sessions. So it would be nice to give you all your certificates and tell Shire that we need to go and party somewhere nice, like Haifeng or somewhere.
Where's that?
So the next
Next Sunday is Sunday 28th, which is 7:30.
I've got it.